We do this Maisha Conference, which is the 7th in this country. We pray that, Lord, you're helping us even to accomplish what we had planned to do. Guide us. Help each one of us to take responsibility of their assignment. We thank you, Lord, for the many movements we are doing, coming from all over to Mombasa and back. We pray that you give us journey mercies. We pray that you deliver us from every manner of evil. You keep us all the time that we shall be here in Mombasa. And we thank you, Father, even as we go back home, you're giving us strategies to win against HIV. We thank you and we bless you. In Jesus' name we pray.
Thank you very much, Steve. Colleagues, fellow delegates, and distinguished guests, I just want to thank you for yesterday, for your patience and for your resilience, and to particularly bring you the compliments of the Principal Secretary for Medical Services, Ari Kimtai, who said he was amazed by the patience that he saw in the room, that after waiting for so long, when he was walking out, still the room was full. Can you kindly clap for yourselves for that? Thank you. And we'll continue to receive more guests. I know the other guests who we did not manage to recognize yesterday. I know there's a delegation from Eswatini. I know there's a delegation from Zambia. I know Gilead also, you supported us, and we did not when the names of the partners. And if there's anyone else whom we left out yesterday, kindly bring it to our attention so that we may recognize you. Also this morning, we have been joined by Mamadou Laminso, who is the Chief Education of the Education Program of the UNESCO Regional Office in Eastern Africa. Maybe Mamadou, you can stand up so that we can acknowledge you. Kindly clap for him. Welcome. Later. Yes. Thank you very much. For purposes of just confirmation, although we were a bit late yesterday, we want to confirm that the following sessions indeed took place. The session on managing epidemics through multi-sector actions, success stories in the HIV response and COVID-19. That session indeed did take place. What works for our young people, the session took place, leaving no one behind. Ensuring HIV progress for key and vulnerable populations, KVP, that session took place. Aging and HIV country preparedness. Did that session take place? No. When is it taking place? This afternoon. Where, Davis? We're told here. Okay. What time? At 2. So we will make an announcement then. So let us all be aware that those ones who wish to attend the aging and HIV, you attend your session here after lunch. Managing the complex layered challenge of ending AIDS by 2030, the triple threat. We had that session here yesterday in this room, and it was graced by His Excellency Governor Rotich, among other dignitaries. So we were happy for that panel. Ending AIDS among children in Kenya by 2030. Progress and strategies. Did that session take place? It took place, eh? Good. So it's only one session from yesterday that we are carrying forward to today. I think we'll do a good job. So for today's session, to begin us off, it will be a plenary, after which we'll break into our group sessions at break time, meaning that everyone will come here this morning. And the session today is on building resilient public health systems to manage epidemic strategies, to manage epidemics, strategies for preparedness and response. We know we have been through a lot of shocks of late, emerging and re-emerging epidemics and pandemics. And to take us through that session, I want to invite the session chair, Dr. Deus Bazira from Georgetown University, to introduce his panel and proceed with the rest of the session. Daktari, karibu sana. Makofi ya daktari tafadhali. Thank you.
Good morning and welcome once again. I hope you all had a very peaceful night and you are all refreshed and ready to tackle today. This morning, my my colleagues and I hope to entertain you in a different way from Pato yesterday. We'll be entertaining you through a very lively discussion. We'll be inviting you at the end of our brief remarks to actively participate in this discussion, because the topic we'll be addressing this morning is building resilient public health systems to manage epidemics, strategies for preparedness and response. And I think, given where we are today, just about 3 years since COVID-19 pandemic hit us, I think we've all become experts and participants when it comes to managing epidemics, outbreaks, epidemics, and pandemics. So I expect and welcome all of you to participate. Once again, my name is Deus Bazira. I represent Georgetown University in the United States, Washington, D.C., a Jesuit Catholic university, the first in the United States, set up in 1789. I serve as the inaugural director of the Georgetown University Global Health Institute. I'm also a co-founder and currently director Center for Global Health Practice and Impact at Georgetown University Medical Center, and I hold an academic appointment as an associate professor of medicine. Prior to that, and for relevance to Kenya, I was the founding director of the Center for International Health Education and Biosecurity at University of Maryland School of Medicine. You know University of Maryland in Kenya as CHEB. So I was the founding director of CHEB at the global level. So welcome. So what are we going to be talking about today? We will be focusing a lot of our discussion around issues of preparedness and response. And preparedness is something we talk about these days in light of COVID-19 pandemic, but are we really prepared to deal with the next pandemic or the next health threat? We know prior to COVID, we had very well articulated global and national preparedness and response plans. In fact, a lot of countries had gone through what we call the joint external evaluation that gets done by several organizations, including WHO, UNICEF, and national governments. And a lot of countries scored very well, meaning that they had capacities to prevent, to detect, to respond, and to rebuild if there was such a big event like a pandemic. The United States, where I currently live, was ranked #1 across all capacities, but we also know how the country eventually responded to COVID-19, and it registered the second highest per capita death from COVID-19 after Peru. So there was a lot of disconnect between how we assess preparedness and how we actually got to act when we got tested. So we don't want to make the same mistake next time, and trust me, there will be a next time. So when we talk about preparedness, it's within the context of addressing public health threats, mostly around disease outbreaks of infectious nature. Outbreaks are not surprises. Disease outbreaks happen all the time, and we know it. The question is, how do we deal with them? Because they are not random acts that simply occur. Our failures, in most cases, are influenced by our failures to make the right investments in core capabilities we require to be able to respond if an outbreak happened, so that we can stop it from becoming an epidemic. And then, at least if we fail to stop it from becoming an epidemic, we stop it from becoming a pandemic. There are shortcomings in governance structures at a global level, but also at national level. And in many countries, we tend not to have strong sub-national structures and systems that allow us to quickly detect things at a local level and be able then to work with national, regional, and global actors to respond. Sometimes we also tend to have conflicts between who is responsible. Is it the global institution like World Health Organization? Should it be WHO Afro in Brazzaville, or should it be now Africa CDC in Addis Ababa that takes the lead, or should it be Ministry of Health in Kenya? And then when we get to the national level, it becomes a question, who takes the lead? Should it be the presidency? Should it be the Minister of Finance? Should it be the Minister of Defense? Because we've seen when it comes to pandemics and disease outbreaks, they are not just health issues. They are economic, they are political, they cut across the security sector. So what that means for us is that for preparedness and response to work, we need a multi-sectoral approach, and we also need interdisciplinary approaches to do this. So today is not about me. I'm not going to bore you with my commentary. We have an esteemed group of panelists, experts in their fields, but also participants and people who have been affected by pandemics. I will be calling upon them to join me on the stage. I will introduce them one by one and tell you what they'll be talking about. Each of them will be given about 10 to 15 minutes to make their presentations or their remarks, after which I will ask them a few questions. When I'm done, I will open up the panel for the audience to ask questions and try as much as possible to interrogate these issues, because this is a topic that we are all very much interested in. We want to make sure that at the end of the day, 5 years from now, 2 years from now, we've built a public health system that works for all of us. And what that means is we have a public health system that is able to provide routine, essential health needs of the population, while at the same time, it's got inbuilt capacity and resilience to respond to any threats that may come up. And we don't have to pick between one or the other. We can deal with an outbreak, we can deal with an epidemic, while at the same time performing surgeries and immunizations. Okay, so to start us off, I'm now going to invite the first panelist to join me here, who will be addressing the issue of institutionalization and utilization of effective alert systems and the generation of data and other strategic information crucial to timely decision making. To respond, to detect, to prevent, to rebuild, we need data. And so this gentleman I'm about to introduce will be covering that topic. And this will be Dr. Samuel Kadevani, who is the head of Integrated Disease Surveillance in the Ministry of Health. Samuel is a highly accomplished professional with extensive experience in epidemiology and public health. He holds a Bachelor of Medicine and Bachelor of Surgery from the University of Nairobi, and he's got advanced degrees in applied epidemiology, business administration, health economics, and health policy. Throughout his career over the last 2 decades, he served at various levels within the Kenyan government, and he was very much involved in the responses that happened in the past, whether it's against COVID-19 or some other outbreaks. He's an accomplished publisher, and he's made remarkable contribution to this space. So we look forward to welcoming him and to hearing what he has to share with us today. Dr. Samuel Kadevani, please join me. Our other speaker and panelist is Dr. Virginia Gitau, who is the country implementation lead for CCA project under Elizabeth Glaser Pediatric AIDS Foundation. Dr. Virginia will be addressing lessons learned from integrating COVID-19 into routine health services, a topic that we all know is very dear to us. Integrated delivery is the way to go. We cannot afford to run things in parallel. We've got only one health system. It has to be able to address all our needs. Dr. Gitau is a public health practitioner, but he's also a trained doctor, and he's also been trained in infectious and non-communicable diseases with more than 10 years of experience in critical care and public health emergencies. She remains passionate about resilient and sustainable health systems. She is the right person for today. Dr. Gitau, welcome. Next is Ms. Anne Okaro, who is the National Chairperson, Kenya Network of HIV Positive Teachers, KENEPOT, that's what it's called. She's a senior educator with more than 30 years of experience. And given the focus of yesterday's discussions and the fact that Kenya's population is largely a young population, Ms. Anokaro is one of those that has been charged with the responsibility of educating the next generation of leaders and the next generation of citizens that are going to make Kenya great. So she has more than 30 years of experience with the Teachers Service Commission or Teaching Service Commission. She's a commissioned stigma champion, motivational speaker, and counselor, and is also a film star. She's an actress. So we have a celebrity with us today. She's currently writing a book, My Darker Moments, and this book will be launched next month. I encourage all of you to buy it. I apologize, Ruth, I'm not doing marketing for her book, but I think it will have a lot of things to tell us. She's also had experience as a HIV home-based care provider. She's a Global Positive Land Support Representative for East Africa, a member of several technical working groups. So she's going to be speaking to us addressing this issue of preparedness and resilient public health systems from a user's perspective. Anne, you're welcome. Okay. Then we have Ms. Kamunto Kenani from the Ministry of Education in the Director of Policy and Partnerships. We all know the importance and the interconnection between education and health, and I think to address these going concerns and health challenges we face, given that the majority of our population is young, school-going age groups, the Ministry of Education is critical and central to all our health initiatives, and we in the health sector have got to make an intentional approach to engage the Ministry of Health, Ministry of Education and the education sector generally in all our public health programming and interventions. Ms. Kenani, welcome. And finally, no, two more. I started mostly with the ladies, but we have two gentlemen left. Mr. John Ekelo, who is the health director of the Seventh-day Adventist Church in Kenya. One of the things that happened during the COVID-19 response, we realized that we knew this, but it became very apparent that there is diminishing trust in public health science and public health leadership. A lot of emerging evidence shows that there's been an erosion of trust in a lot of institutional leaders and institutions. However, the faith sector remains one of the most trusted institutions. And so the global community, and I encourage you in Kenya, should be exploring how we can take advantage of faith leaders and faith institutions to improve our public health messaging and risk communication, and get faith leaders to be champions and representatives of public health messaging. So Mr. John Okello is going to help share with us the faith perspective in how we build resilient public health systems. And finally, I invite a colleague of mine, so Dr. Haji Ibrahim Bola Gobir. He's also from Georgetown University. He's the regional director for Georgetown Western and Central Africa operations. He's also a CEO of Georgetown Global Health Nigeria, which is a local organization that Georgetown supports. He's an assistant professor of medicine within the University Georgetown Medical Center. He brings more than 25 years of experience and has had field working experience in more than 7 countries in academia, public health, and healthcare delivery. Currently, he acts as a principal investigator of a health security award in Nigeria and several countries, and he's been working with CDC Atlanta to develop a Center of Excellency public health emergency management program to help strengthen resiliency and preparedness for country public health systems to deal with pandemics. So he's the right person to talk to us about the future. Dr. Gobir. Now that the introductions have been made and respecting all protocols, for all the distinguished guests in the audience, I will quickly move on and invite our first speaker to address us, Dr. Samuel Kaduvani. You're welcome.
Yeah, thank you very much, Brother Wazira. As told, my name is Dr. Samuel Kadivane, but I normally allow the ladies to call me Kadiv, so feel free to call me Kadiv. My task today is to really look into how do we build resilient systems, particularly in surveillance, in which we talk about detection of cases, being able to manage those cases, and also eventually rebuild in the event that we have had an outbreak and it's over. Much of our discussion is on lessons learned from our COVID-19 pandemic. We in surveillance thought we had a very good and effective systems, only for us to discover that we might not be as prepared as that. So I'll start by just defining what is surveillance. And in this case, we use the WHO definition, which is quite wordy. It goes like ongoing, systematic collection, analysis, and interpretation of health-related data essential for the planning, implementation, evaluation of public health practice, with closely integrated with timely dissemination of this data to those responsible for prevention and control. If you look at this definition, it is quite wordy. So for us as surveillance officers, what we like to put across is that surveillance is nothing but is it moving? Excuse me, it's not moving? Yeah? So for us, eventually what we talk about is surveillance is nothing but data for action. Surveillance is data, and more data that helps us take some action. So there are different types of surveillance, which are health facility-based, sentinel, laboratory, and disease-specific surveillance. Particularly of importance is that we've been dealing with HIV, TB, malaria that have their own surveillance systems, but eventually we come up and integrate all of them into one system. For surveillance in Kenya, the story starts in way back in 1998, when it was realized that there are so many surveillance systems that were being for specific diseases. That was malaria, there is TB, there is HIV. So the World Health Organization, the Afro region, actually came up with what is now called the Integrated Disease Surveillance and Response Strategy. That is the IDSR. So as you can see from that pictorial, from 1998, we had our first integrated disease surveillance technical guidelines, and that came into action in 2002. Then as we moved along, we did the trainings, we had an IDSR scale-up, then we also had the weekly bulletin that normally gives us a very good projection and reports on whatever outbreaks we will be having in the country. In around 2008, we also had the IHR, International Health Regulations, that came into effect in 2007. Then around that time as well, we did have the need for concentration on non-communicable diseases, the NCDs. Then as we move along, we also went and had a revision of the guidelines in 2010. And around that time, you remember, we actually had some pandemics. That is the avian flu pandemic, if you remember. Then also concentration on zoonosis. As you know, 70% of our diseases actually zoonotic in nature. That is, they actually are of animal origin. So why that IDSR strategy? I think that was, that is our key goals. To integrate, instead of having several systems, we link all these into one particular system. These are just the historical perspectives. Then they also came to a point of having international health regulation revised, and the initial ones were for 1969, and we moved further to 2005, and we had the international health regulations reviewed, and at that particular time, we had a need to focus on more than 3 diseases. The initial diseases were cholera, a plague, and the yellow fever. But now we have moved to several other diseases as well. I don't know, this one is not. Move to the next. Yeah, next. Okay, so why did we have the international health regulations? It is mainly because the world is changing at a very fast rate, and diseases travel fast. Nowadays, you can have a disease, take breakfast in one particular continent, and lunch, have it in a different continent, and also have your supper in a different continent. So the diseases travel faster, and that is why we have to bring in the international health regulations. What does it call for? It calls for strengthened national capacity, prevention, alert, and response to international public health emergencies, global partnerships and international collaborations, as well as rights, obligations, procedures, and progress monitoring. Currently in Kenya, we have what we call priority diseases. And next. This one doesn't seem to be working. Okay, just move to the next. Yeah, so talking about 46 priority diseases, conditions, and events. And of course, with the introduction of what we call One Health. One Health basically talks about 3 aspects of disease control. Number 1 is the human aspect. Number 2 is the animal aspect. And then number 3 is the environment. The interaction of all this gives us what we call a One Health approach. What has been the impact of IDSR? When implemented well, it improves early detection, early reporting, and leads to prompt and effective responses. Where IDSR is fully implemented, it has improved response time and reduced morbidity, mortality, and also the duration of the outbreaks, pandemics, and epidemics. There is a need for use of innovations in technology to strengthen e-IDSR, such as mobile telephone, health approaches, e-learning, and also e-teaching. So what are the lessons that we learned from COVID-19? Number 1 is that surveillance is critical because it provides regular updates on the occurrence of diseases, conditions, and events. We also came to learn that we need to have a whole government approach. There are various sections that are supposed to interact. There's a meteorological department, there's a Ministry of Education, there is security. As you remember, even during COVID, a big aspect of COVID ended up being a security issue. Then we also need to know now we have surge capacity. That is capacity that you have just in case there's an outbreak or an epidemic. you can be able to call in extra staff to combat that particular situation. So we also have pre-positioning of emergency response supplies. That could be drugs, vaccines, as well as personal protective equipment or PPE. A great importance is also now attached to risk communication and community engagement, which is addressing the issues of misinformation and the disinformation that is particularly found on social media. As regards this detection, we are revising our case definitions, which actually assist in identification of cases, conditions, and events. We also have improved laboratory capacity that we've had. Remember during COVID, you only had 2 labs that were able to do the test, but even as we move now currently, we can detect more cases, basically because of improved diagnostic capacity. In terms of technology, we have introduced the genomic sequencing that enables linkages between outbreaks in different regions of the world. Then there is modeling. There is now a wider embrace for modeling in predicting future outbreaks. Of course, we have also had improved technology in terms of vaccine production and enhanced surveillance at the points of entry. It goes without saying that we are now having what is known as epidemic intelligence from open sources, that you can be able to do scanning of the media all over the world and come up with anything that is touching on a particular condition, which is the way we are moving forward for easier detection. In terms of response, the need for early response in case of outbreaks, which prevents morbidity and mortality. There is preparedness and response plans that are in place now, and also testing these particular plans through simulation exercises. There is the introduction of incident management structure, which is the international gold standard in terms of managing any outbreaks or epidemics. Currently, we have also embraced the public health emergency operation centers. Initially, there was only one national one, but for now, we have around 18 counties that also have public health emergency operation centers. There is improved ICU capacity in terms of response, but as you realize, initially, mainly ICU capacity was at the national level, but it has now gone down to most of the facilities at the sub-county and county level now have emergency ICU capacity. Yeah, so the other developments, of course, that came from COVID is development of the digital surveillance systems. If I can just mention one, the Jitenge Plus, that is used for contact tracing. So you no longer have to do contact tracing from each particular individual. You can also use the technology. Then, of course, embrace of the virtual meetings. Now that we have virtual meetings, it's easier to even do review of surveillance reporting rates and all that. Then, of course, legislation. Currently, there is a review of the international health regulations, which has been initiated following what happened in the COVID-19 pandemic. Thank you very much.
Good morning. My name is Kemunto Kenani from the Ministry of Education, and I'm going to present on re-emerging from the COVID pandemic. That is our experience. Okay, that is technology for you. I'm not going to talk about the mission and vision of the ministry because today that is not the issue. I just want to go directly to the time when we closed schools after the declaration of the pandemic in March 2020. And then over 18 million learners and trainers were supposed to stay at home and await for the reopening of schools. I am sure if you flash back that time, I'm sure that was the most interesting time of all the times we've lived in because we've never known what a pandemic is. And we thought that probably it is something that is going to take us a few weeks, a few months, only to be told now we are no longer going to work. We are no longer going to teach. Our learners were going to stay at home, be with their parents. And then later on, everything else was closed. You can imagine a situation where you are having over 18 million learners who are staying at home with their parents. Parents who are not used to having their learners in the house for that long. Just imagine having teenagers in your house running up and down, but they're not going out to play. That was the situation we found ourselves in. And then it was thought quickly. We had already started the program of DLP, digital learning, and thought that now that we are digitalized, we can actually move learning to the digital space until the challenges came on. One, this is a mode of transmission of knowledge that was untested and unmonitored. We hadn't tested this. We didn't know which kind of content to give our learners, but we expected them to learn. And then learn how? With parents who, some of them did not have electronic gadgets. There was poor connectivity and lacked source of power, and it meant that people with or without smartphones, parents without smartphones, without laptops, their children could not learn. Then, of course, the same parents could not even be able to support their learners because, for one, even them, their knowledge, most of us, our knowledge is limited to specific subjects. And then a child is coming home with all types of homeworks. There's mathematics to do, probably there's chemistry, there's science, there's Kiswahili, and most of you hate Kiswahili, yet it's the easiest language. And you can imagine, a parent is supposed to support a learner at that level. That parent is also not idle. Remember, that parent is also occupied somewhere with their duties to work, probably working online, and then the same parent is supposed to support a learner, and therefore it became very, very difficult for these children to do their homeworks. And sometimes in some of the schools that I saw, they could send homework to the parent will assess the learner, then send the results to the school, which became impossible because even some of the areas the parents were being told to support, they did not understand them. Now, capacity of parents to teach and guide learners, mark and transmit assessment online was definitely a huge challenge. And then accessing libraries physically was difficult, and people did not even know how to access libraries online because we did not even know which libraries existed online. In situations where learners with special needs and disabilities existed in the families, they were even more ignored because now even the parents did not even know how to support these specific learners with learning. And when student assessment moved online, it was purely a trial and error thing because we have never done it before. We didn't know how to do it now. Probably at higher levels, masters and PhDs, for those who've done it, assessment can be done. Your work can be marked and assessed and given results, but not with the lower grades. So homeschooling became a completely new thing to parents, and I think that is a challenge in the country that it is something that we can embrace if we look at the modalities on how to homeschool, so that now learners are not left idle, doing nothing because there's a pandemic. Remember, these learners are stuck in the house, and therefore, development of social skills and social awareness was definitely affected, because now they were only intermingling with family members, not people outside the family, like their playmates and their schoolmates. Progression and transition of learners from one class to the next was also affected, and definitely when most of the learners realized that probably they are going to repeat school, it brought in anxiety and stress. And because of the closure, most of the teachers who are teaching in private schools lost their jobs or income, so to speak, because those schools felt that because the teachers were not going to school physically, they were not entitled to any salary. And what happened next? Reported cases of teenage pregnancy. You remember they were all over the press that now in Machakos, we are having so many girls pregnant. Kids were indulging in drug and substance use and abuse. And therefore, when we looked at the whole situation, it could tell you we were actually very unprepared for this particular pandemic. And as a result of the situation within the homes, even within the education sector, a lot of anxiety, depression, and stress was experienced. What did we do? As a ministry, the first thing is the ministry appointed a COVID-19 National Education Response Committee with a mandate to develop modalities of reopening when we realized, or when the government realized that the situation was improving. And after that, they developed a training module for teachers and officials so that they could enable, put in place the health protocols in preparation for the reopening. And then the school reopening modalities and protocols were put in place. We also developed the drug and substance use and abuse and management guidelines so that we could also address issues of substance use and abuse in schools. And we also developed a positive discipline guidelines, which is yet to be launched, but it will be soon be reopened, launched. Then we said, now we are ready to open. The circus started. Before we even realized it in January, when we reopened, approximately 200,000 students did not report to school. And therefore, the mopping exercise had to be done even more deeper than it used to be. Initially, we used to do mopping only in January, but it persisted all the way to sometimes in March, so that we could locate some of the learners who had dropped out of school and we did not even know where they were. So the head teachers were mandated to know where those learners were and ensure that those learners were readmitted. Of course, cases of truancy increased, which also affected achievement of the 100% transition policy of the Ministry of Education. And as a result of the closing down of schools, there was the introduction of the crash program. Crash program was a disaster. If you can remember very well, kids could not even participate in co-curricular activities. There was no music, there was no drama, there were no sports, and therefore tension increased. And as a result, we saw, by the time we go to October, over 200 schools had already been raised down. And therefore, it was the mandate of the Ministry of Education to rebuild them before they came up with sanctions later on in 2022. There was increased anxiety and stress for both the learners and the teachers, even the education staff. But what did we get out of this? There is need to reduce the digital divide to enhance online and remote learning. We are glad that the Open Learning University has been put in place, but the question is now on accessibility. Who are they going to admit with the kind of cost that we saw? Through a multi-sectoral approach, We must invest in prevention of teenage pregnancies and other related factors to ensure a return to school for all learners. Remember, do not discriminate and saying your program is supporting only boys. Where do only girls? Where do the boys go? Because they're also children of Kenya. There is need to revitalize the Ministry of Education community service learning platform and to support establishment of safe spaces during school holidays for skills building opportunities. We can have hubs where they can go learning on technology and innovations. There is need for joint intervention by the health and education sectors to address mental health issues. I remember during Uhuru Kenyatta's tenure, he requested that we developed a mental health policy, and up to this time, I do not think the policy is in place. There is also need for community movements to address the issue of substance use among adolescents. It is within the same community that these kids are drinking and smoking and using substances and nothing is being done. There's link rite of passage programs with comprehensive curriculum that covers value of all gender and mental health among other life skills. And there's also need to recruit trained guidance and counseling teachers to provide psychosocial support for learners. Remember, most of the guidance and counseling teachers in our schools are self-trained. They're not trained by the government, and they're not employed by the government. They actually give free service to the learning institutions. So I think it is high time we also employed guidance and counseling teachers to be specifically there for guidance and counseling purposes. Otherwise, I want to thank you so much for listening to me. Thank you.
Good morning, everyone, once again. I'm a Nigerian, to start with. And sometimes I like to wear my dual hat of being a Nigerian and also living half and half in Nigeria, and then as well as living in the US. And when the chair started earlier on, he said, we are here to entertain you. And I said, if I had known this, I would have been wearing the Nigerian entertainment hat, so that I would come in here and entertain you. But I was already well entertained, and I can say that Kenyans can equally match Nigerians when it comes to entertainment, especially with regards to what Patu did yesterday. So thank you guys for entertaining us. Next slide, please. Thank you. So I really would like to start by again showcasing Nigeria. We are all over the place, to be honest. Even walking into the hotel, when I checked in 2 days ago, Nigerian songs were playing all over. I felt like I was home. Coming in here today, even the jazz sessions were all Nigerian songs. Sometimes I almost get into the mood of, trying to dance and, just have fun and enjoy myself. So yeah, we're a population of over 200 million people. We have about almost close to like 400 tribes in Nigeria. So it's pretty difficult to be able to have one tribe that will be, or one language that will be the national language, in Nigeria. I know a lot of people here will probably watch Nigerian movies and the rest of them. So here I am representing everyone in Nigeria. Next slide, please. So instead of putting out a true definition from either WHO, UN, US, name it, of what we're looking at when you're talking about preparedness and resilience, I try to go back and look at a couple of things that have happened as I engage in my own public health career. Now, this is not a picture that we took in Nigeria. This is actually when Georgetown University started implementing HIV care and treatment program in Cameroon in 2020. And then we're supposed to go for field assessment. And we embarked on a field assessment, a joint field assessment with CDC, interestingly. The Georgetown program, we are like maybe 5 or 6 of us. And then while we're going, we were all cautioned that this particular part of Cameroon, in the eastern part of Cameroon, for us to be able to go to this place, we would need armed escort. Now, we are not the ones that travel with the armed escort. The armed escort was by CDC. But then, of course, we had to follow the convoy to be able to access this place. So the convoy was there with armed escort, and then there was also the road network that we had to navigate. And that sort of prepared me for that experience prepared me for any other event, because they drove very well in a very professional way. And I felt I was prepared enough for the next event that was going to happen in Nigeria a couple of weeks back, maybe 2 weeks ago, in the southern part of Nigeria. Oh, we're going to start a fellowship program in a place called Edo State. And they said we need armed escort. This time around, we had to provide our own armed escort. So we have these mobile policemen with rifles and everything, hillocks in front of us. And they packed all of us, both Georgetown staff, the government staff, in a bus. And I thought myself, man, I wasn't fully prepared for this, because the driving was different. I was prepared for the initial phase when you zoomed out of the airport and the driver was driving like, swerving from one place to another. It was as if you were watching either Schumacher or Lewis Hamilton driving. These guys were moving on a road like this at a speed of like 140. And so I had to activate another part of preparedness that I wasn't ready for. And thank God we have the clergy here, and that you guys also started your session with prayer. And I started by activating different prayer points. And I can tell you that my prayer points kept on changing as we were traveling. Initially I was committing the driver into God's hand as he was driving. Then I had to commit the road network because it was really bad. Then I had to, they were just being thrown from left, right, center. But then we made it, basically. The point is, we had to have been prepared for this, but I wasn't ready to deal with this the way COVID shocked the world. But in between, looking at how others navigated it, I was able to, reorganize myself. I wasn't trained, but at least I've had a lived experience. The buses were kind of equipped, so we have to strap on our seatbelt, no helmet or something. And eventually, at least when I got back, I felt there's a need for us to actually reevaluate this and say, is this the only way that at least we'll have been able to get this done? So that speaks to the context of preparedness as well as resilience that I want to talk about. Next, please. So Nigeria has about 41 notifiable events. We don't typically call them diseases anymore because some of them are really not diseases, like road traffic accidents, for example. And then over the past 5 years, there's no time that we don't have an event occurring in Nigeria. So some diseases are even known to be endemic in the country. So we're always having an outbreak. I'm probably going to hone down on a couple of those outbreaks because that's what we showcase how Nigerians became very resilient to be able to respond to COVID. So we have the Lassa fever. Lassa fever is a viral hemorrhagic fever, almost close to Ebola. But the difference is because you don't contact Lassa fever the way you contact Ebola, but then you have to deal with the rats, because we have the rats that transmit this Lassa fever, and there are communities in Nigeria, that eat rats, they call them grass cutters and the rest of them, and some of them cannot even differentiate between the rats that causes Lassa fever, which is a viral hemorrhagic fever, and the one that you need to eat. Now, cooking it and making it a delicacy is not the problem. It's the process of actually catching that rat and then preparing it. That's when some people end up, but if it makes it to the plate, I want to believe with microwave, you are unlikely going to suffer anything. Bottom line is, we've been dealing with this for the past 5 years. We've also been dealing with cholera outbreaks. Typically, we don't have them in cities, but that's also something that has been occurring in the country, as well as meningitis. Next, please. Recently, we also had to deal with monkeypox in country. Everybody dealt with COVID-19. And of course, yellow fever is also there. These are things that have shaped how Nigeria prepared, because with all of these events occurring, in fact, there's a seasonal approach. Some of them, you can almost always predict when they are going to occur. We get everybody ready, and then we respond. Now, you might want to argue and say that, why are we really, really not eradicating or stopping these things? It's almost impossible to actually be able to get that done. What we've been able to do over time is actually, reducing the number of cases and then reducing the number of deaths that are occurring from this disease. Hopefully, at some times in the future, we will be able to get to that level of eradication. Next. And of course, just like Kenya and Nigeria also have HIV, estimated about 1.9 million people living with HIV in Nigeria. And we've received significant amount of support from the US government, whether it's CDC, USAID, USDOD, and Global Fund too. And the effort and the infrastructure that the donors put in Nigeria has also helped us strengthen the system, in terms of being able to leverage this for pandemic preparedness as well as response. For our HIV program, we do HIV surveillance. We have a robust supply chain system that guarantees that we don't have stock out of drug. The healthcare workforce are always trained, almost on a daily basis, even if you have attrition, people are trained, they are supported. You have technical assistance being provided by partners as well as government. And then there is sustained community engagement even for the HIV program. For some of us who have been in the HIV program for over a decade, you will know that at some point, people have to come to the facility to pick up their drugs. Now we're talking community treatment. You are talking test and start. Things are changing. These are all infrastructures that at least the US government put in place that Nigerian government was able to leverage during COVID. Next, please. Now, we are also having additional re-emerging diseases in country because these things are not going to go on break. We're having diphtheria, despite the fact that this is supposed to be a vaccine-preventable disease. We're having an outbreak. We're having anthrax outbreak again. That was a couple of months ago. And then after declaring Nigeria as being polio-free, we've started recording circulating variants of polio virus in fragile conflict and violent settings. And it's not just occurring there alone. It's because it's actually difficult to actually be able to get into some of these places. You don't want to get kidnapped. You don't want to get killed. But then the country is also prepared because we have folks over time that have been involved in providing immunization or doing immunization campaign like traditional birth attendant. And that's when I actually discovered that even if you're a bandit, you still want to have babies. So they don't kidnap the traditional birth attendants. They want them to be able to come and deliver their wives. So with that, we said, if that is going to work, then we're going to be using this traditional birth attendant to deliver the polio vaccines to the children. And they are doing a great job at actually that. Next, please. So what are the gains? Just to summarize, because this is where I want to hone on most of my slides. The next couple of slides is just to talk about what Nigeria did with COVID, and I don't want to repeat what some of my colleagues have talked about with regards to with COVID. So with all of the outbreaks occurring, the Nigerian government decided that there was a need for us to actually be able to have a fully functional National Public Health Institute. And that happened in 2018. So yes, without that, it would have been very difficult for us to actually be able to maintain and manage. And we go out right now, even at Georgetown University, pitching to most countries to either have National Public Health Institute set up or figure out a way to strengthen existing EPI division of your Ministry of Health to be able to perform that function. Over time, of course, we'll be able to map all of the stakeholders and engage them, in preparedness as well as response. We've also been able to identify early resources and assets that we will need for emergency response. Now, you need to understand one thing. We don't focus these resources only on a national level. We go down to the subnational as well as community. And then we also build capacity at all levels. Again, we are lucky over time, the US government through CDC has supported us to actually, roll out public health emergency management training program. And of recent, of course, we're also being funded by CDC as a university program to develop a Lassa fever clinical management fellowship program because of the way, of course, they've seen Nigerian government prepare and respond to events. We have all of the emergency operating centers operating at national as well as subnational level. Community engagement is something that is ongoing and we're still maintaining, including engaging religious and traditional leaders. We've identified some of those treatment centers and, sort of twist them over time to actually be able to respond to different outbreaks. So it's not just for Lassa fever alone. These treatment centers, as well as their lab, are the ones that were already positioned to be able to respond to COVID. And that was why it was a lot easier for us to actually be able to get that done. And then we do all of the after-action reviews. We don't just respond, but then we conduct all these after-action reviews. We do tabletop exercises. We do simulation exercises to be able to enable us to prepare and become resilient for the next pandemic. And again, like I said earlier, we're still leveraging the PEPFAR infrastructure as well as global health infrastructure in Nigeria. Next slide, please. So yes, this is just to talk about COVID. Like most of us know, it took just about 60 days for COVID to arrive in Nigeria, and then we welcomed it graciously. Next. Because, like I said, we've already been able to do all of the mapping of the different stakeholders. These are just some of the stakeholders that were engaged, as part of preparedness for COVID. Next, please. So in terms of preparedness, at least what I can say, the Nigerian government did very well. Immediately before COVID even arrived, we didn't have a red carpet, but we had to roll a red carpet for it. So at a national level, the Nigerian government had to, form a national COVID-19 preparedness group. And these are some of the functions, that they serve there. I don't want to read through most of them, but they were there to provide the leadership. And then secondly, next slide, you can go on. We also have to, figure out a way to manage our port of entries. They were preparing them to get them ready. They have to introduce technology solutions. They have to make sure that people are already well-trained using the existing training infrastructure that we have. They now have to also further re-engage the US government through US CDC, USAID, US DOD, because they are really the partners that were involved in running and driving HIV program. And because of the challenges between, there's HIV, there's TB, some people were struggling with, how will you be able to differentiate between somebody with HIV, coming down with COVID? And so there was a need to actually do that engagement. In terms of response, the government introduced or inaugurated the Presidential Task Force for COVID response, and these are some of the things that they had to do. Next, please. They were always doing daily briefs. Some of the pictures that I have here are the pictures of the chairman of the Presidential Task Force and the Nigerian Center for Disease Control, the then Director General. We have to transition to a full-fledged emergency operating center. We have to engage over 150 corporate bodies and multilateral as well as bilateral organizations. There was the rapid deployment of rapid response team to 35 states in Nigeria, including the Federal Capital Territory. Nigeria has 36 states, but one of the states refused to accept COVID. So that's why we have 35 years. We have to set up drive-through centers, and then we have to be able to continue to engage the government, track our supplies, and then further strengthen surveillance activities at port of entry. Nigeria is not landlocked, so we have the waterway, air, as well as the land borders to actually be able to put the right team in place to continue to conduct surveillance. Next, please. And then, as Georgetown University, we had to look at institutional resources to see how are we going to support the Nigerian government. What did we do? We developed a microsite that was actually tracking everything that was happening with regards to COVID response. And that's what we have in the image below. So they were able to look at the epi curve, track all of the cases, and then use that to guide how decisions are made with regards to lockdowns, social non-pharmaceutical interventions that were put in place, as well as the pharmaceutical interventions. We had to scale up testing laboratories, leveraging existing infrastructure. For example, with the PEPFAR, there was the gene expert that was used for TB diagnosis. They were using it for EID. They were using it for viral load. We also have to be able to leverage that infrastructure at that point in time for COVID. Public-private partnership, of course, was now intensified, and then we have private labs springing up to be able to complement and support what we are doing and all of the effort. And of course, as we're also managing COVID, we now have to also start doing a couple of COVID-related research so that we're not just relying on research that are occurring out of the country, we are also doing our own research in Nigeria. Next. And then, of course, the vaccine, like every other country, tried to, do the vaccine rollout. At least I know I probably took vaccine twice until I had to talk to my boss, who is the moderator here, and he told me that, look, he has taken vaccine 4 times or 5 times. And then because I was traveling, I've also had to take the COVID-19 vaccine multiple times. So we try to encourage everybody to take the vaccine as much as possible. And the picture you have there is our president. Then he was actually the first to be vaccinated, and then everybody followed suit. I think one thing that I want to stress here, which is my last slide, is what the US government is actually also supporting us through US CDC. No, the slide before, which is the Public Health Emergency Preparedness, Response, and Recovery. Now, as opposed to the FEM training program that we're already implementing, this particular one is actually meant for the entire ECOWAS region. So we are actually engaging all of these countries with funding from the US CDC to implement this training program. We are bringing folks from all of the Africa, all the ECOWAS countries to Nigeria next week to go through the process of requirement gathering and developing content, because the content is going to be different from the traditional EOC FEM training. This one is bringing community leaders, it's bringing religious leaders, it's bringing everybody for us to actually be able to develop this particular fellowship program. And that's something that we're hoping will start sometime next year, and it's going to be funded by the US CDC. And lastly, next slide. I tried to summarize everything here with regards to the take-home point, and everything that I've talked about with regards to preparedness and resilience, and how Nigeria has been able to deal with this speaks to the leadership involvement. The legislation for the MPHI to function, this is very important, and I believe very strongly that Kenya will need that at some point to be able to have a national public health institute with clarity of rules, having all of the backing and the funding that they need to actually be able to get their job done. You need to be able to harness existing resources or even leverage existing resources. In addition to that, to actually make it sustainable. If some of us remember the 3x5 or 5x3, you are looking at sustainability, you are focusing on program, you are focusing on finance, and then you are focusing on the political part. That also has to come into play when you are looking at how to actually prepare and have a resilience team. And of course, you have to continue to engage the community at different levels. Last slide. I want to acknowledge everybody that has supported me in getting this done, including Deus himself here, my colleague Mercy in Nigeria, Winifred, and then Joshua, who packaged the presentation to make it look a little bit pretty. Next. Thank you, and I hope I've entertained you enough.
Thank you. Good morning, everyone. It's very hard to follow after Dr. here, so kindly have mercy on me. My name is Dr. Virginia Gitao. Okay, so my name is Dr. Virginia Gitao, but better known as Gina. So Jina langu ni Gina. I just want to talk a bit about what we've done in regards to the COVID-19 pandemic and the lessons we've learned moving forward. So ECPAF, as we highlighted yesterday from our country director, thank you. Is an NGO that is 35 years old. In Kenya, we're almost 25 years, ignore the 22, and we work in 7 counties. So we primarily began in HIV and AIDS, and we've used those lessons in the HIV pandemic response to help us manage the COVID-19 response. So you can ask yourself, thank you. You can ask yourself, why COVID versus HIV? And if you look at the 2 conditions, they're actually quite similar. If you look at COVID, it brought about a lot of economic disruptions. It's a high burden to someone who has had or has COVID-19. You think about the money you have to spend for treatment. The same thing goes for HIV. There's a social economic implication. You look at the gender, there are people who are more vulnerable to getting COVID or HIV. You look at also how it will affect treatment for other conditions. But then mental health is something that I think we've brought up and is a big thing. There's mental health challenges associated with both COVID-19 and HIV. Stigma was present for HIV. We're trying to mitigate that. But with COVID, at the height of the pandemic, if my colleague here was to cough next to me, I think you'd find me at the other end of the room, right? So there was a lot of stigma, there were a lot of myths that were coming, so we had to find a way to counter those myths. And then also the chronic complications that come with both conditions. So COVID, there's something known as long COVID, and those are people who have a lot of complications after their initial infection with COVID-19, and they're never the same. With HIV, we've talked about advanced HIV disease. So there are a few complications that come with both conditions. So we as ECPAF, thank you. So we as ECPAF decided to use the lessons that we know about pandemic response, focusing on HIV, and start the CCA project, which was a catalyzing COVID action project. So what we aim to do is that in every facility you go to, when you're coming for your regular MNCH, your TB, your CCC clinic, you're offered free COVID-19 screening and testing, and if you're eligible, you're also given free treatment. So that's what we term as integration. So this is just the goal of the CCA project. We're aiming to accelerate access to novel diagnostics and treatment. So at the height of the pandemic, who remembers how expensive the PCR tests were? I think they were in the $9,000, $10,000 range. That's around, I think, $90 to $100. But we're able to provide free antigen testing, and you'll see why this is key. We're also able to provide free therapeutics, a medication by the name of tocilizumab. So if you're eligible for treatment or severe COVID-19 treatment, we'd give you that. So as we set out this project, what we did is that we had different work areas. So we were trying to gather evidence by doing research alongside with the project implementation. Then we're also able to ensure that supply chain was catered for within Kiambu County by providing now the diagnostic and therapeutic reagents. Then we're able to ensure that we engage the community, we have advocacy. Because we can have a lot of ideas, but if the community is not aware of what COVID is and how we can manage it, then we're not doing much. Lastly, as we even plan to exit, we want to ensure that the systems we've put in place are sustainable so that Ministry of Health and even the community person is able to carry on the rest of the services. So did this integration work? Like I said, you come into the clinic and you've come in to be seen with a particular condition, but we offer COVID-19 treatment services. So yes, it did work. We were able to actually ensure that even as you come in, we all know when we go to the hospital, it's a full day affair, isn't it? Even if you're coming to see your consultant and you're told your appointment was at 9:30, you'll probably end up seeing the doctor at 11 or 2 p.m. if you're lucky. So we're only able to use an extra 4 to 5 minutes to ensure that these patients who came into the clinic were screened and tested for COVID-19. We're able to reduce the missed opportunities and link these patients to care. One thing that revolutionized the project is that we stopped using paper. So now any patient who comes to these facilities, they're screened through a tablet, and we get real-time data in our dashboard. So at any given point in time, I can actually tell you right now there are 4 patients who've been seen for COVID-19, and anyone can access that dashboard. What it does is that it gives us real-time data so that we can use it to make decisions. And moving forward, I think using digital platforms such as the Kenya EMR is something that can actually cut across various conditions or pandemics. That's just a screenshot of the Kenya EMR. We're able to get the COVID EMR integrated into the Kenya EMR. So let's talk about this intervention. Does it work? Should you integrate COVID or any other condition into clinics? What we saw is that out of the patients who attended overall within Kiambu County, we were able to actually screen around 80 to 85% of those patients. And out of those patients, we're able to find almost 10% of them eligible for testing. These are people who, had they not been screened, I would have missed them. They would have probably come to the hospital for any other condition, malaria, you name it. But now, incidentally, because we were doing the COVID-19 testing, we're able to get those results, and we're also able to link all of them into care. What we saw with those is that, of course, let me not be biased as a woman, a lot more women were able to be tested. A lot more women turned out to be positive, but this is because we had a lot of women, sorry, let me just go back. A lot of women attending the clinics. Oh, sorry, this is a different slide. Sorry, that's not updated. So we had majority of the women in MNCH, the Maternal, Newborn and Child Health Clinic, being eligible for testing. But our greatest positivity came from the outpatient department. What does this mean? If I am pregnant and today I have fever, I have a cough, will I wait for my clinic in 3 months to see my gynecologist? No? Yes? No, I'll go to the outpatient and I'll be seen. So the importance of integrating diseases in one point is very important because our highest positivity came from outpatient, not from the TB clinics, not from the CCC clinics, not from MNCH. We also found that our highest positivity was between the children aged between 5 and 14 years. So it's also good to raise awareness with children about what COVID-19 is or any other pandemic that may come. We found positivity to be also higher in the people aged 50 years and above, and which was consistent with the national data. Looking at the wave, obviously between 2021 and 2022, we found severity had come down, so we found a lot more people having mild COVID. What does this mean? It means that before, we used to look at COVID as a very severe illness, but now it's come and people think of it as a common cold or a flu. So we need to raise awareness as the pandemic shifts so that people are able to access healthcare and know what they need to access. So what did we learn? We learned that integration is possible. So if Ebola comes, if cholera comes or has come, we should be able to have a holistic approach. So we don't need to have a disease-centered kind of management or surveillance system. We need to be having integrated systems. We also realized that going the digital way enables us to get real-time data, and that data we feed to the team at National, and they're able to generate evidence and come out with response strategies. We've done a few interaction reviews and after-action reviews, and that's basically looking at what we did versus what we should have done and the lessons that come from that. Then community engagement. Like I said, COVID came with a lot of myths, a lot of stigma. We're able to engage the community and tell them what COVID actually is, what they need to look out for, and how they can protect themselves and their loved ones. Then we're able to involve all healthcare workers. Like the people who were screening the patients were actually community health promoters. So using them to spread that message both in the facility and outside the facility actually resulted in a lot of positive response. And we're also able to strengthen our coordination mechanisms. So moving forward, what are the lessons we've learned from the COVID-19 pandemic? One is multi-sectoral engagement, and I think we've worked with a few bodies, including the NSDCC, the National Public Health Emergency Operations Center. We've worked with health promotion to ensure that we're able to relay the message of COVID-19 in the appropriate manner, using the right IEC materials and promotional materials. Sorry. We've also learned that Okay, this is misbehaving. We've also learned about the importance of digital health and having an EMR that actually tells us what is happening on the ground and utilizing that data in a realistic manner. We've realized that risk assessment is important. So know what you have in the country, what you have in a facility, what you have at subnational level in regards to the bed capacity, to the critical care capacity, and even HR capacity, so that when another pandemic comes, you're able to model and prepare the right stuff adequately. We've also learned the importance of continuity of essential service, and my colleague highlighted earlier about closure of schools. So in a lot of countries, the school feeding programs, the immunization programs were actually interrupted because children are not going to school, so they were not able to access those kind of cares. So as we're focusing on the pandemic, what do we have in regards to the catch-up plans and the response plans? And this actually goes to our recovery and reutilization plans. So we built a lot of nice hospitals, we had a lot of nice ICUs, or critical care capacity. We trained a lot of personnel on critical care, on IPC. What are we doing with that resource? So what is the repurposing plan that we have as a country at national, subnational, and even facility level? How will we utilize, let's say, that level 5 facility that has an ICU and maybe change it to a cardiac center, a transplant center? Or are we going to have those machines and those skilled personnel just lying dormant? Then lastly, we should have systems ready for any upsurge, so that if you train a particular group of people about surge capacity, you know that tomorrow, if we're told Ebola is here, then we have a trained rapid response team at county level, at facility level, even at national level, so that we're not running around trying to catch up with a disease that has already gotten away ahead of time. So I think that was my last slide. I'll just say thank you to UNITAID, National and Kiambu Department of Health, also to the WHO, NSDCC, NASCOP, and all our other implementing and development partners. Thank you.
Let's applaud our panelists. I think they did a fantastic job. Thank you all. So we only have about 40 minutes left, and my intention is to get you out of this room at exactly 11. We don't want to use any extra time. So the next session is going to be a very efficient one. So I'm just going to invite two other panelists who didn't speak but have got prepared remarks. But their remarks will focus on addressing a common question that every panelist will be asked to answer in about 2 minutes. After that, we'll open the discussion to the audience. So we all like talking about lessons learned, experiences we've gone through in responding to different threats, whether it's outbreaks, pandemics, road safety, traffic accidents. If you are to prioritize based on your experience and what you've been doing, what do you see as critical 2-3 priority actions we should take within your area of expertise to strengthen and improve resiliency and preparedness of our public health systems? So the panelists, when you come up one by one, try and focus on making those 2 to 3 priority action steps that should be taken, which is different from just lessons learned. Now we've learned, what do we do next going forward? So I'll start off with John, coming here to share with us their own perspectives from the faith sector, and then my sister here will go next, and then the panelists will follow.
All right, good morning. I'm John Okello. I work with the Seventh-day Adventist Church. I'm also a member of the Faith Technical Working Group of the now National Syndemic Disease Control Council, previously National AIDS Control Council. I'm here to talk about the response to the pandemic by the faith community. I just want to start by giving what I heard yesterday. This lady, this young girl called Chebet. Those who are here up to late in the evening, she gave a moving story about herself. But what touched me out of the story she gave is about the support system. And she particularly mentioned that there is a gap in parenting and bringing up people in a way which the community would expect them to be. I remember she mentioned that. And you know, when she mentioned that, I wanted to ask her this question, but there was no time. So I asked myself, where is the support system for these people who really need this kind of support? And in terms of pandemics, disease outbreaks, and other conditions like mental health. Then I proceeded to ask myself a question: where's the faith community? Where are the religious leaders? Are we really in the community, or are we really among the community? And are we really being felt in terms of responses to these disasters affecting the society? That's a very critical question, which probably the public has a perception on the faith community and how we handle most of these issues and most of these pandemics. But when I ask that question, it's like we are the ones, the faith community and religious leaders, to critically look at ourselves and try to find out, are we relevant? You know, yesterday when introduction was being done, you know, we are a system. We are a faith community. We are a stakeholder, and we are very key in addressing these issues coming up. But the introduction was unique because there was no mention of the faith community. There was only a mention of, we also have our religious leaders among us. But remember, the religious leaders are part of the faith community. So that I want that perception to be taken into consideration. Now, going into the presentation, how does the faith community respond to pandemics? First of all, if we give our historical perspective, experiences, it was a disaster for us as a faith community. All of you know, because studies have given the fact that over 97% of the Kenyan population subscribe to a certain faith, and they go to church or to the mosque over the weekend. That's Friday, Saturday, and Sunday. And so you know exactly what happened. When there was COVID-19 outbreak, how did the church respond? You know, at first, it started with the resistance. You people remember. Because we told we may have to close the churches, because that was one of the preventive measures, control measures, to be taken to ensure that this disease do not spread. And at first, there was a resistance. Why? Because of issues and matters of faith. But we were not looking at it from the aspect that the more we congregated, the more we would be spreading the disease. But we thank God that after consultations, let me just call them consultations, with the government, it was agreed that the churches, just like any other institution, must be closed. And for sure, for some time, the churches were closed. So what happened? Did they have other alternative measures? Yes, they did. Quite a number of churches did, and especially those ones which have technology with them. We went virtual. People were meeting through YouTubes, people were meeting through Zoom, because they still wanted to get the spiritual word. And you will find that some studies were done. I remember our lead speaker saying that there's this issue of trust. And this issue of trust is, what can we do? Now, what we have decided to do as a response, number one, we have a leadership structure all the way from the national level up to the local level that makes us a complete system. We also have our health systems. We also have our health facilities. This response requires us that we have to relook at the leadership and the training of our theologians. We may have to relook and have a conversation on our curriculum in our theological seminaries and colleges. Can we introduce units, certain units on the health, issues of health, even at the very, very fundamental level? Can we appreciate issues of health so that it can be acceptable? Then number two, we usually have congregational teachings. I don't know whether you can scroll very fast because I know my time is up. We have congregational teachings, and this we did, just scroll down. This we did, just continue scrolling. This we did in response. You know, we were not prepared for the pandemics, but now, yes, up to there. We had to be forced to develop some certain messages so that we can teach people in the congregation. We must make sure that they are enlightened. You know, we are basically focused in our teachings, focused on spiritual health, social health, and other aspects of health. But we are not focusing on physical health. This is where the gap is. And we want to ensure that our religious leaders understand this so that we can seal this gap. Just continue scrolling. And so you will find we have got a number of materials we have developed, which we are using. Just continue scrolling, so that we must make sure that we understand. The number three is our health systems. We must make sure that we strengthen our health system. In Kenya, some times back, the data said that 40% of healthcare services are offered by the faith-based organizations. And so we must make sure that we strengthen. How do we respond? The human resource, the community health systems, the supply chain. This was a big challenge for us as a faith-based organization. We kept relying on the government to help us with certain things. But coming time with this antigen X, we must make sure that as a faith community, we are prepared to address these issues and also improve on quality. This is key for us. I think let's so to prepare for this, we have to focus on leadership from the national level to the lowest level up to the congregation. We have to appreciate, finally, we have to appreciate partnerships. Very key for us as a faith community. Partnerships, number one. Then number two is that faith communities must appreciate the role of science in control of diseases. We must appreciate that. There could be certain issues, a few issues could be there, which brings controversy. But generally, the faith community must appreciate the role science plays, because all the interventions we did put in place were based on science. They were based on science. And focusing basically on behavioral aspects of controlling diseases. The question is, are we ready for the next antigen, which can come anytime? The faith community must address its systems, must address issues of leadership. We must appreciate partnership, and we also must appreciate science if we have to work together as a faith community and address the pandemics which are coming over. We can't do it alone, but together we will make it, all of us. Thank you so much, and God bless you.
Good morning, everyone. I think I'll be very, very brief. My name is Anne Okaro, the National Chairperson for Positive Teachers in Kenya. And talking after my boss from the Ministry of Education has talked, sometimes you have to be brief. Yes, COVID came, and I think in my 30 years of teaching, that was the most difficult time. We learned a lot. And we also saw gaps, especially with parenting. Parents have forgotten their roles. They have heaped everything to the teachers. That was the time a parent could call you even in the middle of the night. Mwalimu, I need pads for my daughter. Yet they are having them at home. Simply because the government provided for that. There is a need for education. There is a need for linkage between the Ministry of Education and the Ministry of Health to put us prepared for any pandemic that comes along. There was disruption during that. Schools were closed without any formal plans. Teachers were being asked to send homework. Some of the parents do not have smartphones. The ministry was still looking at the mean score at the expense of the health aspect. So I think for me, education, and mainly the health education in schools, that program, I think, is a program that the ministry should put a lot of emphasis in. And those of us who are living with the disease, we are actually forgotten. Nobody cared. Yesterday, somebody said that children are the last people who are thought about. So for the teachers, they were taking care of themselves as well as taking care of the children. Parents were somewhere. Right now, we are going towards the long holiday from October to January. The parents are like, teachers, why are you bringing us these children? But my question is, as a parent, what is your responsibility? We had COVID. Even sending children with masks was a problem. Parents were like, mtapewa shuleni. So my challenge to everybody seated here, I think the school setup should really be given support. I really want to appreciate the National AIDS Control Council. You know, the syndemic, it's still heavy in our mouths. But we are proud of the things that you've taught us, especially for the teachers living with the disease. The empowerment we have got from the National AIDS Control Council. They are doing the work that the Ministry of Education is supposed to do. I'm sorry about it, but let us say the truth. So I think from here, when we get back, the ministry should sit and come up with programs to support the teachers, to support the learners, and also the parent. Because what the teacher tells the parent, when a teacher speaks to the parent, it is done. Like now we are having the several health campaigns. It is through the schools that we realize them. So because of time, allow me to say this. We need to put a lot of emphasis in the education sector. Education, 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 and sensitization. And that is the only way we are going to be in a prepared situation when the next pandemic comes. Thank you so much.
Thank you so much. So in the interest of time, the panelists are not going to answer my question. Instead, I'm going to give one member of the audience to ask a question that will be answered by the panelists in the next 5 minutes only. So first come, first served. Any question from the audience? That gentleman put up his hand first. I'm going to give you the opportunity to ask. Maybe you want to come close to the microphone so we can hear you. Please take it to that gentleman.
Thank you so much to the panelists. I'm Gideon Koriri from Kericho. And my question is, what are the mechanisms that have been put in place for the youths and adolescents who are in school who are taking the drugs? Because we have realized that most of these school going, when they're in school, they go for drug holiday. What are we going to do so that we can maintain the low viral load? Thank you. Thank you so much. I was asking, what are the mechanisms that is in place or that the ministry, more so the MOE, are putting in place that we have teachers who are also taking medication to see that they can help the youths and the adolescents who are in the same school, but during the school time they go for drug holiday because of the stigma, and more so during the inspection in school. What are we going to do so that we can cap this thing and avoid the drug holidays in schools?
Thank you so much, Coril. I think we have programs running in schools to take care of the teachers who are on ARVs as well as the learners. In most of our schools or counties, we have commissioned stigma champions by the Teacher Service Commission who work closely with the children and teachers living with HIV. We have psycho-support group in our counties for both the learners and the teachers. And in most of these schools, we have introduced something we call the buddy system, which is working very well. The buddy system helps the learners in full adherence and also to fight the stigma and discrimination amongst learners. So if there is a challenge where you are, I think it is us to take upon it ourselves to give you the support. Otherwise, in other counties, it's working, the psycho support and the buddy system. Thank you.
So a question from a sister in the audience. Definitely, I will have to defer to you, Professor Ndwati. I'm going to give you the opportunity to ask the question, the final question. Thank you.
Thank you very much. I come back to that same question of children, the health of children, the teachers, and the parents. And I've been consistently wondering, in the large boarding secondary schools, the audience, the number of students there are like a catchment of a dispensary. And my question is, why are we not placing a qualified health worker as a member of staff in the staff room to take leadership in that process of supporting health issues in the school? I've had the privilege of visiting one of the large schools. I went to visit Gillies High School. I was tagged along by my spouse. And the space where used to have 600 students has 3 times the number of those students. I had a chance to interact with the Form 1s and Form 2s, and all those children had the face of a child who's looking shocked, you know, the flat affect of a child who is in a very, very stressful environment. Now, this is not going to disrupt the school immediately. It is not immediately noticed. But this kind of stress and the lack of identifying it and working on it has very, very long-term ramifications. So my suggestion is that instead of trying to transform a teacher to being a health worker, let us put qualified health professionals in the school. Those children are citizens. There are enough of them to justify a health facility within the school. And then one last point. We underrate the impact of the AIDS epidemic on parenting. The people who you're calling parents, those ones who are sort of dishing the children away, these are the survivors of that period of time. They did not have the benefit of being mothered the way or fathered the way we want children to be fathered. So they don't have that knowledge in their subconscious. In central Kenya, You know the problem of alcoholism, desperate young men. That is the story of transferred trauma. Your grandparents were away, so the parents didn't learn how to parent, and they carried the trauma of growing up without a parent, and now it's going to the next and the next generation. So we need to take those into account as we try and raise a different generation. Thank you.
Thanks, Prof. Asked and answered. If there's going to be one takeaway point from this session, as part of ending the triple threat and learning from the COVID-19 experiences, and as we build towards a more resilient future, I think one takeaway message, and I hope the policymakers in the room will take this very seriously, is how we bring health, holistic health, into the education learning spaces. Because I think we don't have to always be stuck with the traditional structures of the health system. Health is impacted by a lot of determinants, and education is a big one. So how do we bring structured health support, health promotion, and healthcare, certain parts of healthcare, into the education system? So I would like to take this opportunity to thank all the panelists. I wish we had more time to entertain questions from the audience, but one of the responsibilities of the moderator for the session is that I have to respect rules. And the rules that the time that was allocated to us is ended, and I would like you to take your break in preparation for the next session. What we are going to be doing as the panelists will pull together a post-conference report summarizing everything that has been discussed, including recommendations and action steps that were not presented here. Hopefully, through the Endemic Control Council and the Ministry of Health and Education, some of these recommendations could also be considered for policy and programmatic action. Once again, join me in thanking the panelists and thanking the audience for your participation. Thank you. You talked about the one point at the end you brought up is what I wanted. That's like faith, trust, coming a big issue. In fact, I have the Lancet, we call it the Lancet Commission. Yes, I am.